At this point, we will move to Ricardo. Ricardo is a very gentleman. He is a director of Pediatric Intensive Care Unit in Puerto Rico, in University Pediatric Hospital in San Juan, Puerto Rico. He is also the director of the Pediatric Critical Care Fellowship at the University of Puerto Rico School of Medicine. He's speaking to us tonight or today, according to your time, about the pediatrics and the COVID. So welcome, Ricardo, and thank you very much for your time and effort. And please, for the audience, if you have any question, please just type it down in the Q&A part, and we'll do our best to answer it. Thank you very much. The floor is yours now.
Thank you. Let me share my screen. Thank you for the invitation, and to Gloria for her wonderful lecture. We will talk about a little bit of different people now, the children, and we will talk about how this pandemic has affected children, how is that epidemiology, define the disease severity in pediatrics, and risk factors for children, what are we doing for the management of these kids, define the other disease process that we have seen in pediatrics, the multisystemic inflammatory syndrome, or MISC, and PIMS is another term used by the World Health Organization, the risk factors, what are the current management, the outcomes, and touch a little bit on what already Gloria talked about prevention strategies. So in children, since the beginning of the pandemic, the transmission was a concern among children, and that drove the lockdowns and the closing of schools, since children historically transmit viruses to other people, mainly from studies on influenza. And that's one of the reasons that the children get immunized for influenza, not so much because they get so sick from the disease process, even though they can get sick, because they used to transmit the virus, they were considered super spreaders. But as the pandemic evolved, and we have seen on time, the percent of cases in the US and the world of patients with COVID-19 remain relatively low, less than 7% in some areas, or 1% when you look at the overall hospitalization rate, depending on the series. And the COVID-19 death related to children has also remained relatively low. There was a publication in England where they estimated that 1 in every 50,000 children will get to the ICU, and almost 2 in a million will have an absolute risk for death. So when you look at the hospitalization rate, and this data from the CDC up to November 27th of this year, the cumulative hospitalization rate, the red bar is the total number of cumulative rate of hospitalization over 100,000 people, and the little black dots is the percent of those hospitalizations to belong to pediatric population. So we're not getting hospitalized as frequent as adults, a lot, and the rate has remained low even though with the variants. So what is disease severity? In children, there are several studies that we'll talk about briefly that define it as children who get admission to the ICU, needs non-invasive or invasive ventilation, or died from COVID. From this pragmatic definition, our patients that we treat are just as the adults using the World Health Organization definition, patients with hypoxemia, moderate ARDS, signs of respiratory distress, radiologic evidence of pneumonia, support, mechanical ventilation, and in addition to septic shock, multi-organ failure, and increased inflammatory markers. So let's quickly review what we already, mostly of us, know about coronaviruses, but try to give a insight or why children are responding differently. And we know that we get exposed to a virus or a bacteria, and we have 2 components of our immune system, the innate immune response and the adaptive immune response. Once we get exposed to the to the virus or the sorry for the sun that is in my face. So we get the response from our immune system, the neutrophils, monocyte, macrophages, and dendritic cells produce pro-inflammatory cytokines, and those promote the identification of the virus and the neutralization. And at the same time, or a little bit later, our adaptive immune response with T cells and B cells produce antibodies, plasma cells that get rid of the virus. And this was a review published by Medicine and Pharmacology on innate and adaptive immune responses against coronavirus from last year, 2020. And we knew from our previous experience with immune response to SARS-CoV-2 that we get exposed to maybe a lower titer virus titer, like the masking has helped also to decrease the spreading. I think more than even the lockdowns. You get your activation on your innate immune response. You may get hospitalized or not, and you mount a normal immune response and recover. Some patients, and depending on the high virus titer, may get a more severe activation of this immune response, which at the same time, these pro-inflammatory markers promote tissue and cellular damage, get the patient on ICU, multi-organ failure, and increase the risk of death. But we are not seeing that same immune response in pediatrics. So what is the difference, or what are the theories? Well, there is this publication from the Journal of Science and Nature that talks about the reduced development of COVID-19 in children, reveals molecular checkpoints, gating pathogenesis, eliminating potential therapies. And basically, to your left in the cartoon, you have the adults, you have the children. In pediatrics, the pediatric population gets common colds by coronaviruses or other coronaviruses. So one of the theories is that the epithelium is more primed to respond to the viral infections because of the previous exposure. They have less AC2 receptors on the epithelium. Also, we know that the spike protein, in addition to getting to the AC2 receptor, it gets anchored to the TMP-RSS2 receptor 2, and those are less common also in the alveolar cells of the pulmonary epithelium. The immune response of the children to the production of interleukin-6, that has been also a marker of increased inflammation in adults, is not as robust in pediatrics. So also it is thought that immune response is more appropriate for the exposure to the virus. And also there was a theories or concepts that patients that were vaccinated recently or has been exposed to vaccinations, the innate process is more robust as we get older, or the gets older, our adaptive response gets more robust. So it is what protects us at the long term, but in the short term, the innate response is the one who helps us to cope with the virus. When you get to this other paper from Science Translational Medicine, they studied the immune response of SARS-CoV-2 infection in hospitalized pediatric and adult patients. And basically they found that the pediatric patients had shorter lengths of stay. They were less need for mechanical ventilation with a lower mortality. And basically the main difference was not so much the interleukin levels, if not the antibody production or the adaptive response was lower in the pediatric population, arguing or going in favor that the immune response is not over exaggerated from the natural immunity. Also that the naive T cells that the patients have or children have more ability to mount new response than the ones that are already trained for other disease process from being in the adaptive immune response. So that gets us then what all the risk factors, because we see COVID-19 in the ICU, but obviously with a less frequency. And these two papers, one from Italy, they review all the cases that they had at the beginning of the pandemic. It was published on Pediatrics of October of last year. And then this other paper on Pediatrics also, but this time published on this year on November. It found that patients who were younger than 1 year age get higher risk for get hospitalized, but they were not an increased risk of death. Patients with pulmonary problems, diabetes, I place there that the US experience is higher. The incidence of type 1 diabetes as a risk factor for getting hospitalized compared to other countries is not found that same reason. Sickle cell disease, congenital heart disease, immunosuppression, but mainly the last three things: genetic disorders, neurologic disorders, metabolic condition, medically complex patients, and obesity has been the most common reasons for ICU admission and the higher mortality in that group population. It was thought that the high number of patients that were getting hospitalized less than a year old in the hospital was more related to, we as a pediatrician, we see a child or an infant that is sick and we don't know what the course of the illness was going to be. They got hospitalized not because they were too sick, if not more concerned of what was going to happen. And that has remained like that even with the incidence of in the pregnant females that develop COVID. It has been shown that neonatal transmission of the COVID is very low, with low risk for the baby, more risk for the pregnant woman if she's not vaccinated, because they end on with prematurity, and not because the baby gets COVID-19 infection. More the risk associated with the complications on the baby are for premature labor. So what do we do for management? We use what you use in for adults. There's not much data on pediatrics, even almost 2 years later of the pandemic. We know it requires a multidisciplinary approach. We still get preparation of the ICU, multidisciplinary staff, personal protection equipment, isolation rooms, and the respiratory support and the management has evolved over the last few years. We know now that we don't delay the support based on risk for transmission as the personnel. We will provide oxygen, high flow nasal cannula, non-invasive ventilation, and even conventional mechanical ventilation. As Gloria mentioned, ECMO is limited to high resource centers with a mixed experience in pediatrics, from 80% survival rate if they end on ECMO to only 20% survival on ECMO. So it will depend on your resources. But again, overall, the mortality is low and the support system remains the same, and the management. Remembering that high flow nasal cannula is still the first line of therapy. We use the isolation room and we place a mask over the high flow nasal cannula to limit the spreading or the embolization of particles. And we titrate to give adequate oxygenation and a relief of the respiratory distress in the patient from the standpoint of respiratory support. If the patient gets sicker, the evidence have shown us that we should not delay intubation, that we can do early pronation even in patients who are not intubated. We can promote changing the position. I guess in pediatrics it's easier to prone a 1 year old or 2 year old versus 80 kilo adults, but it's not difficult or taxing for the personnel. But again, a lot of protection of the or the problems relate to the protection of the personnel or having enough PPE. Remember to use high PEEP, low tidal volume ventilation, limit your plateau pressure, driving your pressure less than 15 or 18 if possible, and follow the ARDS guidelines. So all this involves optimization of the respiratory system, following respiratory mechanics, and all this that we heard before about L and H compliance. It all depends and it evolves between the two. We use nitric oxide. We don't have access necessarily to ECMO. So we, if patient is not improving, is still very hypoxemic, we will give it a try. Remember to keep it well. Nutrition, hemodynamic optimization is essential to keep prevent secondary organ damage and multisystemic organ dysfunction. Like we say, a dry lung is a happy lung, so fluid balance is essential to the management. Patient safety, central access to avoid losing IV access or sedation, personal protection equipment for your healthcare worker, and follow strict guidelines. Usually, the pediatric patients that remains in the ICU, the length of stay remains less than 7 to 10 days, even with COVID. More being sicker usually may remain in the ICU longer just because of the isolation room and avoid moving the patient around the hospital. So the therapies are the same as a year ago, or 6 months ago when we talked. We don't have much difference in pediatrics yet. We're still using remdesivir for patients depending on the age and the weight, because there have been studies talking about the safety. We are relying on the results from adults to talk about the effectiveness. We use dexamethasone up to the dose that adults use of 6 milligrams per day. And in the case that they cannot receive one of those, we also may use baricitinib as an alternative for immunosuppression, and even in severe critical care patients. We do not use convalescent plasma as an alternative therapy. There is not enough data to prove that it helps the pediatric population. Even in the adult population is not robust data that it will help the patient by the time we are so much on severe disease in this particular population. So there was limited data, like I say, on the use of remdesivir. The authorization was given us with emergency, but the studies published on Pediatrics on May of this year shown that it has low threshold for adverse events or toxicity. The study was not powered to show difference in mortality or decrease on mechanical ventilator days, but it's, anyhow, in the study population, the mortality rate was relatively low. Were only 4 deaths from the patient population that was studying this paper. So other therapies that does not has zero data to be used in pediatrics. Some of them already was mentioned by Gloria also. We talk about hydroxychloroquine, ivermectin, famotidine, all those. There's no data to prove that they decrease the length of stay or decrease the severity of illness in pediatrics, and even less to prevent the contagious or progression of the disease in less severe patients. So what we see, what happened with children who get, so this is a slide that showed before May that was up to January, showing that the mortality rate was less than 0.1% in the pediatric population defined as less than 18 years of age, compared with the other age groups that are seen there. And when you see that data from the conglomerate data from the CDC up to November 27th of this year, I know it's not well seen, but in your far right, it says age group. The 4 bars that represent pediatrics are these 4 that are here, and they never go up, even though when there are spikes in mortality, when there were clusters or increase in the incidence of cases in the adult population, in pediatrics, it remained low. We did not see, even with, that we saw more positive patients with Delta variant, but we did not see an increase in the hospitalization rate on the ICU or mortality associated with the variant. We saw that there were more positive cases, but not necessarily using the healthcare resources. And the graph on the right is talking about the same, that mortality overall as a group is less than 0.1%. So before talking to prevention strategies, the other disease process that we see in pediatrics is called multisystemic inflammatory syndrome. And basically it was defined by the CDC and the World Health Organization as a disease process that affected primarily children less than 20 years of age, had fever for more than 24 hours. In the World Health Organization, it says 3 days, had markers of inflammation like CRP, sedimentation rate, procalcitonin, ferritin levels, LDH, IL-6, neutrophils, and they also have evidence of clinical organ dysfunction that requires hospitalization. Among the organs that may be involved, there were cardiovascular, respiratory, renal, GI, neurologic, dermatologic, and or look like Kawasaki disease. For those of you who are not pediatricians, Kawasaki disease is a kind of an autoimmune disease process that is seen on children from 3 to 8 years of age that usually presents with high fever. It is known because of cardiovascular dysfunction and the development of coronary artery aneurysms, which can cause infarcts and make the patients die. So these patients started presenting on England and New York, and they were noticed to be like Kawasaki. But when they did testing for COVID, they found that they had prior infection, even a positive test by PCR, serology, or antigen testing within 4 weeks. It is now thought that up to 6 weeks also, you can have the infectious process. Interestingly, these patients, when they had the test positive and they were classified as MIS, some of them had respiratory symptoms, but the respiratory symptoms belong to the cardiovascular dysfunction. They were in heart failure. They may have pulmonary edema, more than having criteria of ARDS as a part of the presentation. So this slide on your left, by March of last year, there were 3,185 cases on the registry from the CDC. Up to November 1st, it went up to 5,526. The age group that gets more commonly in the disease process are usually between 9 to 10 years old, up to 13 years old. Interestingly, the mortality is less than 0.1% too, but we have seen that there was a more prevalent occurrence among Hispanic, Latinos, and Black African Americans, but still not related to the genetic predisposition. I think that the patients are getting sicker because they have inequality on the access, especially in the US. And 60% of the patients were married. Risk factors, the management of this patient population became standardized, more or less. Patient who gets with shock to the hospital in pediatrics and met the criteria for MIS will get admitted to the pediatric ICU. Supportive ICU care, universal precautions. At the beginning, we were putting all these patients in isolation because we didn't know if they were infected from the standpoint of COVID. We have learned that they are not, because usually it's past infection, not active infection. And the goal-directed management was to reverse the shock status and start immunoglobulins G intravenously at 2 grams per kilo, total dose of max gram of 120. Since this can be volume, a little bit of a volume challenge for the patient, depending on the cardiovascular status, it will be given over 24 hours or over 48 hours. They will also get methylprednisolone, 2 milligrams per kilo a day, and they will get aspirin as prophylaxis up to 81 milligrams daily, and they will get low molecular weight heparin prophylaxis based on individual patient risk factors. Those usually will be adolescents. Interestingly, in a difference from adult population, pediatric population thromboembolic events is extremely rare, even in COVID. So the use of low molecular weight is very specific, not standardized for the use on this patient population. So what the literature says that happened with this, there was a study in Colombia called MISCO study that was published in BMC Pediatrics from this year. And basically they review all the patients that were admitted to the different ICUs in Colombia. And they found that they had a similar presentation. The most common sign of presentation was cardiovascular instability and shock. The other most common symptom other than the cardiovascular system was GI symptoms. And they had a little bit higher mortality rate as compared with other published series. And they postulate that maybe the reason for the increased mortality was access for the medical care, because not all the patients where they got hospitalized, they had got all the resources to manage a patient with shock or need for hemodynamic support. There was also a review from the International Journal of Emergency Medicine that also they look at the therapies and what they have been shown. And again, it has been shown that immunoglobulins and corticosteroids either or promote a recovery of the patient and good outcomes. There was a publication in JAMA looking at the combination of the therapies like we do, that is immunoglobulins plus methylprednisolone versus immunoglobulins alone. The main difference on this publication that they found was that the patient became febrile and faster if you combine the therapies, and that has been our experience with the patient that we have had, that we go usually 24 to 48 hours, the patient is febrile, and the hemodynamic instability also resolves with a good outcome. The patient usually recovers, and the extent of the disease, if they will develop aneurysms in the future, is still to be seen, because again, there's not so much follow-up yet, or has not passed enough time to see what will take, if any, change in the patient to the future. So the outcomes of this disease process, the incidence is low, usually follows the peak on adult cases, not including cases in pediatrics. Again, asymptomatic pediatric patients mostly. Even if the adult gets sick, they may or may not get COVID or notice that the child got COVID. And we see after the peak waves of the adults or the surge in the adult cases, then we see 4 to 6 weeks later that we get a patient for the emergency room or in the ICU that has missed criteria. The mortality remains low, and the higher risk identified is access to adequate support system for the pediatric population for that child. When we look again at the mortality of COVID and MISC, still less than 0.1% overall. So what about then pediatrics and all this deal with in the management? So in pediatrics, we have had a lot of changes secondary to the pandemic. We know that the family is vital for the recovery. We know that effective communication as vaccines began to roll out was important. We as pediatricians promote vaccination, or we get all our vaccinations usually when you're a child. So because we know that vaccines but the impact of not having enough people to be cared, the limitation of visiting hours, all that took a toll on the emotional support that the child gets while he is on the hospital, and changed at some point. What we usually do is that we always provide company from the parents, or one of the parents, while his child is in the ICU, and we took care that no child, in spite of the disease process that is going on, being COVID or non-COVID, never should die alone. So Kasid Manan, I don't know if I'm pronouncing it well, but in an editorial from the intensive care unit, intensive care medicine of this year, of June, he summarizes very well with this cartoon of the coronavirus, how the pandemic affected our pediatric population. Well, it provoked a lot of cancellation on semi-elective surgeries that got delayed, that the families cannot visit their loved ones in the hospital or the ICU. We have seen the worsening of the inequality the children got affected because they cannot go to schools, and the adults, we kept going out, but the children has to remain home. Again, at least was an initial impression from what we knew for that they can do with influenza. But as the data roll out, also the media didn't help. Like Gloria was saying, we got mixed messages and the people got a little bit hesitant of what to do with them. Mental health got affected on children. We saw an increase of suicide attempts getting admitted to the ICU from being in the lockdown. We know now that social media is not so social. You need to socialize to be more effective in your development skills. In some places, because the ICUs were emptier, we saw a lot of patients going to adult, a lot of our ICU staff going to adult, to give support to adult ICUs. That also took a toll on the staff. We had children who get delayed presentation to the hospital, so they presented them with a different spectrum of signs and symptoms. And we saw also an increase in patients with non-accidental trauma or battered childs, mostly secondary to the isolation of the parents leading with them, working with them. So caring for these children requires still a multidisciplinary team, like Gloria was saying. This is not only physicians and nurses and equipment. You need the housekeeping. You need the one that brings the food. You need the one who takes the samples to the lab. You need the laboratory technician. So we have to take care of all those people that they do not get a burnout because of the disease process or the pandemic has caused on us. And finalize prevention strategies. I just mentioned that children do not get as sick, that children do not get as, the mortality rate is relatively low. And we have, there is data that proves that children that get sick from COVID are not the one who spread us on, or super spreaders in school. There are several studies that show that mostly patients who get sick on school that have COVID positive, they got it from an adult, especially in younger children. We are, when I'm saying younger children, is less than 10, 12 years old. Like an adolescent is more like an adult in terms of spreading the disease. So why vaccinate them? Well, because we were talking about earlier, if we don't get everybody immunized, we will keep the virus prevalent in the community and the virus can keep mutating. So it will prevent further control of the pandemic. There is a high movement from UNICEF and the World Health Organization on leading minds online that gets a multidisciplinary approach on the children and how we cope with the disease, starting with the protection to avoid further damage to the psyche of the children and physical abuse that they have been submitted, the delay on their education, as something maybe as simple that we can think that, oh, they get home and stay online and study online. No, they do not have access, equal access to online education or just to keep going to the provider of internet. Social protection, but they can use the mask. They behave better than we do as adults. If you teach them why they have to have the mask, they will keep their mask on. We have seen from the several studies that the masking on children on pediatrics have decreased the prevalence of other viruses like RSV, influenza, but are concerned that not getting immunized like measles, we could have then an epidemic of measles in children because of they're not getting well vaccinated. So we, in summary, to finish, we explained the disease severity of COVID-19 and MISC. What are the clinical course or disease process or pathogenesis that children manifest different than adults? The risk factors that we have discovered in pediatrics that are still for getting a patient on the ICU, that the clinical course is better in children, they survive more because of depending on the comorbidities, and how the evolution of the critical care management has went from doing some things at the beginning of the pandemic, and now it's more support care than anything else, and focus to prevention. And again, reflect about how prevention strategies can keep us safer. That will be all. Thank you.
Thank you very much, Ricardo, for this nice lecture. It's very evidence-based and comprehensive. And this actually set me relieved, actually, for my kids. You know, there is much worries about pediatric population, not only as physician, but as parents as well. So if Ricardo Gracia is a politician in the Puerto Rican government, okay, what will be your decision for the schools? Continue, go ahead, or lock down till every child is vaccinated, or what will be your decision then?
Well, our experience, like Gloria was saying, Puerto Rico abandoned the lockdowns and did some restriction. When finally the schools opened last August, September, we do not saw an increase of pediatric cases. There were more asymptomatic cases, like somebody in the room or the classroom had a cold, they did the test, they found that the test was positive, and they will get isolated, they will not go to school, but the schools did not got closed. We got a very good response. In Puerto Rico, when you come, you will see everybody's using the mask outdoors and indoors. The people got very used to the masking, so there's not so much resistance for using the mask. And in the case of pediatrics, when the vaccination began above 11 years old, there was a good response. We already have more than 70% of those patients, adolescents, that are immunized. And the group that is between 5 to 11, it is estimated in 200,000 children. And the Department of Health has a good rate of response from people getting them to get the immunization. A lot of resistance, there is always some groups, but again, we as a country has proven that the children has not caused close of schools or a lot of clusters of cases. The adults are still causing the clusters. Usually you can trace them to small parties or activities where everybody got indoor and had low distancing, or they were not immunized.
Thanks. Just there was a question about the vaccination for children, but I think we already have been through this through the recommendations and the lecture. Yeah. Again, thank you. Yeah, go ahead.
Just a quick detail on the vaccine from Pfizer, from 5 to the lower dose. It is important that you get the appropriate dose, meaning usually the dose is like a third from the dose that we got as an adults, but it's not that you should get 1/3 of the dose that it will put on us and put in the child, because the vaccine has been reconfigured in the sense that one of the media that has the vaccine was changed to less reaction. So there were other changes made, not only to the mRNA molecule. It's not in the media that the vaccine is prepared. It lasts longer, shelf life, so it lasts longer, so you can immunize more people. So again, that in the desperation of getting everybody immunized, don't start using the dose of the adults in the children. You have to get the vial that is for that patient range.
Thank you very much. Appreciating answering questions. At the end, we have to thank you again, Dr. Gloria and Dr. Ricardo, for the nice presentations and the comprehensive review of the COVID situation with adults and pediatrics. And thank you everyone attended this webinar. We have more than 100